Hello, my name is Fiona Moss and I was the Director of Medical and Dental Education Commissioning for London. It's been my pleasure to chair the keynote talk at today's International Quality Forum, where we heard Ruth Carnall describe her experience of improving stroke care across London. We have had tweeted questions throughout the session, and some of those questions are put to Ruth after the talk, and I'm going to put to her some of the questions that we've had since then. Ruth, thank you very much indeed for staying on. One of the questions that has come through after the talk is this: has NHS London published flow assumptions and realities for stroke care in London?
So at the start of this programme, we had some intensive work done on modelling of how the new service would work, about where hyperacute stroke centres should be located in order to make sure that the population got access to the services that they need. And we've since then monitored those. So we published that data right at the start of the programme, and we've subsequently published the data of performance against those standards. And that's how we know that, for example, the average travel time to a hyperacute stroke centre for our population is 14 minutes.
I'm going to interested just to pick up the travel time, just go back to sort of the ambulance services, because ambulances are sort of almost hardwired to stop at the nearest hospital. And presumably they now have to go past hospitals in order to get to a hyperacute stroke unit. Could you a little bit just about the work you did with the ambulance service to enable them to work differently?
We were very, very fortunate in having absolutely committed leadership at the London Ambulance Service. So the Chief Executive of the London Ambulance Service, Peter Bradley, was absolutely committed to making this model work, but it was extremely difficult for the local crews whose routine is to pick up patients and take them to their local hospital. So we invested substantially in their training programme and also in some of the technology that was necessary for them to figure out exactly what the nearest hyperacute stroke centre would be and be able to tell the patient's family, be able to connect to the hospital that they were taking the patient to. And we opened the centres not all at once, we opened them in phases so that we were able to build some confidence that this model would work, and we used that to help support crews down the track. So it was a big training and development programme, but we did have absolutely committed leadership from the top.
Thank you. I mean, we heard sort of in your answer to questions after the talk that this work has involved getting together clinicians, general managers, finance directors, training people involved in training, education and workforce, and also the ambulance service. Quality improvement is often seen as almost in the domain of clinicians. But clearly this major improvement is actually, it is not just clinicians, it's everybody working together across the whole piece in the NHS. One of the questions that's just come through through Twitter is, why can't we enshrine quality improvement in the principles of the NHS so we can reduce the politics?
Well, that's a big question, and in a sense above my pay grade, but the NHS Constitution does in fact embrace quality, so you could argue that that has been done, but it doesn't connect particularly well to the front line. In this case, I mean, if you look at Healthcare for London, the round of which the stroke programme was a part, one of the things that we did was to insist that this was part of everybody's responsibility. So if you take my own team of directors, 10 people, all with a wide variety of roles, I insisted that delivery on Healthcare for London was the #1 priority on all of their agendas. And when I did their monthly reviews, half-year appraisals, annual reviews, bonus awards, whatever, that was the #1 thing that they were all measured on, regardless of what their discipline was. So I think that, you know, ensuring that having decided on some priorities, the leadership then ensures that people are committed to them is a very important thing. So it's not just clinical staff who have to be committed to improving quality, everybody has to be committed to it, and that has to be reinforced all the time. But how we use that and use that commitment to distance making change from the politics of the NHS is an age-old question. On one hand, you know, it's fantastic that in this country people feel so strongly about their health service that it is one of their top political issues. That's a great thing. On the other, it makes the process of delivering change in the NHS a highly, highly politicised one, and one which requires a very substantial personal exposure if you're going to make any change.
We're going back to the fact that you've brought together finance, clinicians, ambulance service, etc., to make this change. And just to reflect that one of the ways we work in the NHS is in our tribes: finance, clinicians, nurses. You know, we work very well
Yes.
in our very well sort of hermetically sealed tribes. How do we get them to learn each other's language? Because I've certainly had conversations with clinicians say, "Whoa, the finance director won't let me." And you're just thinking, well, actually, if the finance director knew your arguments, he would see that this little bit of spend you want actually will save a lot. How do we get out of these tribes and actually, not just between different sorts of clinicians, but actually between, let's say, clinicians and finance?
Several levels to the answer on that, and I don't have a complete answer to it. But again, priorities are important. If you try to say that absolutely everything is important and you want everybody to do absolutely everything, then they're going to do what they want, and they're going to do the thing that they think is important. So this point about rigid prioritisation, I think, is important. Education and training, vitally important. So in the case of the stroke programme, which we've been talking about, the educational side of this, the training side of this was a holistic programme, something for everybody. If you train people repeatedly in silos, then they will work in silos in the future. So I think the training side of this for future programmes is really, really important. Showing the results to people. One of the things that we've done with the stroke programme is we've shown people the difference that it's made, the reduced number of deaths, the reduced disability, and people have taken a pride in the achievement of that across London as a whole. And I think that that's brought people together as well. So nothing, breeds success like success. I think people saw that this was important, it worked, they all had a part to play in it, and that's given confidence that they can do similar things in the future.
Actually, that pride is absolutely there. I mean, I was greeted by the chair of the Stroke Association, who came up to me at a meeting and just said, London, New York, Paris. London is the place to have your stroke.
If you're going to have a stroke,
must be in London. Which was sort of, again, is a sense of sort of London pride, which there's been quite a lot recently for other reasons. One of the questions that we've had is sort of links to that. Will the fragmentation brought about by the current reforms make this kind of reconfiguration, the words in the question, is impossible in the future?
So I think I said in my talk, but I'll repeat it again now, that up until March there were broadly 7 commissioning bodies in London, and from the 1st of April there are 74. So there's no doubt that it is a more fragmented structure. And to deliver this sort of change, which is, system-wide, city-wide, it will be much, much more difficult, because those organisations will have to find ways of working together. However, I think on the opposite side of the coin, there are some fantastically important local changes that will be made much more effectively by clinical commissioning groups. They know their population, the GPs on clinical commissioning boards, they live and work in their locality, and they have a connection to their population that we could never have hoped to have. Mm-hmm. So they will make, I think, more effective changes at local level than we ever could. So the sad thing is that we can't find a way of getting the benefit of both. So it's just, in a sense, one thing's had to be lost in order to gain the other. And I think cities like London will have to find new ways of coming together. I have some ideas about what that might be. Academic health science networks, for example, in London could be a way in which strategic change could be led in the future. But more difficult, not impossible, more difficult.
Can I just ask you just sort of an education question in the broadest sense? It seems to me that one of the problems is that doctors in particular look after the patients that happen to come in through the doors of their hospitals or surgeries. That's what we do. Actually, our role as a consultant, I'm a chest physician, my role actually should be the respiratory health for the people who've saved rent. Once you do that, then you're not focused on the institution so much, but actually on the care and the health rather than health care of that population. What can we do to affect that change? Because it seems to me there's a very strong tendency from very, very caring, passionate clinicians to maintain where they are in their safe hospitals or systems.
That tendency is very strong, and it's reinforced by the population, and that in turn is reinforced by politicians. So that's a very, very strong force, and one which is not easily countered. Evidence is really important. So with the stroke programme, the evidence of what works, the modelling that we did to show that this could work for the whole city. So setting standards, being clear that the standards that we aspire to can't be met by every single solitary local organisation, is all helpful at getting people to rise above it. But I guess what we need is many more successes of this type. that show people you can stand above your organisation, you can still deliver improvement, your own career can still flourish, that of your colleagues can still flourish. I think people won't believe it until they see it more often than they've seen it so far.
One of the questions that's come through on Twitter is, can you speak to the key leadership behaviours that contribute to the success of the stroke programme?
Well, the first thing is to be really clear about what the case for change is. So set out the case for what is wrong with what we're doing at the moment and be absolutely explicit about that. Far too many people fudge that in order to avoid offending people who are providing services at the moment. Be really clear about that. Be absolutely clear about the priorities and the resources and emphasis that's going to be placed on. Don't be ambivalent about that. And then I think once having done that, I think the sort of behaviours that are needed are, work across silo boundaries. Do not say, I'm an acute stroke physician in my hospital and that's what I'm going to be forever and a day. Be willing to work across the boundaries that exist between different organisations, between different directorates, between different professions. Be absolutely committed to working with people, to communicating with people, whether that's in the system or outside. So the sorts of behaviours that you would expect good leaders to demonstrate in a collaborative, complex setup like the health service is what you would expect to see here. But it starts with a really clear case for change and a really clear set of priorities. And then after that, backing the right leadership behaviours and visibly not backing the wrong ones is the right thing to do, as it would be with any sort of change programme, no different, in other words, than any other.
And also going back to something you said, which is actually you just took one of the priorities in London stroke. I mean, it wasn't all of healthcare across London, leadership being sort of the art of the possible. You obviously had to be prepared to tolerate stroke being much better than something else, in a sense, although the something else didn't get any worse, you had to tolerate the gap. So presumably one of the leadership behaviours was actually managing that difficult gap, whereas we tend to sort of push everything together to an averagely not very good or averagely okay. You had to tolerate the gap.
That's been the fault of previous attempts at strategy in London. So we had an extensive programme of discussion and engagement with the leadership of all organisations in London about what the priorities should be, and we settled on 5. And they're all, they're big issues, and stroke was one of the 5. And we pursued those until we were satisfied that they would demonstrate improvement. And we've now been able to move on to other things. So as an example, we didn't concentrate on cancer care in the first instance, but that would now be probably the top priority. So we managed an iteration of that during our time in London, started with those 5 and then moved on to cardiac care, vascular care, cancer care, and to an extent now starting to move on to acute surgery and other acute specialties as well.
There's a turbulence. The NHS has to some extent slowed down that progress.
Yes.
Finally, we've been asked, what was the major challenge in initiating such radical change across stroke care services in London?
So, so was the question the initial difficulty?
No, it doesn't actually specify. It just says the major challenge.
So maybe initiating, I think it said initiating. So the problem in initiating this was getting people to believe that we were serious about it and that we would follow it through. So London has a reputation of, having lots of grandiose ideas and not very much idea of how to implement them. So my own boss, that's his favourite phrase, bunch of grandiose ideas, no idea of how to actually deliver them. So I think overcoming the barrier that nobody believed this is possible, the prophets of doom, as my colleague would have called them, overcoming that and getting people to commit their time, their energy, commit their careers, be brave about this, be bold about what can be done, stick their head above the parapet. That was the most difficult thing in initiating it. The most difficult thing in seeing it through was managing the politics.
Okay, Ruth, thank you very much indeed. Thank you for sharing with us your experience of improving stroke care in London. Masses of lessons for all of us, and I hope for everybody who's here at the conference.
Thank you.